we'll get started then. So welcome everyone, and thank you for joining us here for our SCAD walk event. Today is about more than just putting one foot in front of the other. You know, today is about coming together as a community. It's about raising awareness, supporting one another, and, you know, hearing from our researchers. It's about sharing experiences, sharing knowledge, and ultimately collaborating to drive forward the research that's so important to help us understand SCAD. SCAD was founded by patients. I'm Bex Breslin, one of the co-founders and trustees, and I'm sure you've probably met Debbie, who's also co-founder, and fellow trustees Sarah and Harriet. Bringing up the rear. And, you know, the charity is run entirely by volunteers. And, you know, we know firsthand the challenges that come with a SCAD diagnosis. So last year was our 10th anniversary, and we reflected on a decade of incredible achievements. And, you know, it's really thanks to the dedication of all of our supporters, volunteers, fundraisers, who help us to push forward the mission to raise awareness, provide support, and to fund research. So over the past decade, we've been working hard to build a strong support network. We have developed educational resources and delivered training to healthcare professionals. We've hosted conferences and events like this, and we've also awarded more than £476,000 to SCAD research activities. So that research is being conducted by the incredible team at Leicester, the ever-growing team at Leicester, under the leadership of Dr David Adlam, who we'll hear from shortly. And I think perhaps most importantly, the work of SCAD has ensured that people facing a SCAD diagnosis know that they are not alone. So through our support groups, our buddy service, and shared experiences, thousands of people have found information, friendship, and hope when they needed it most. Needed a little bit of it today myself, I think. So we did launch a new fundraiser recently on Just Giving. So we're working to raise £25,000, and this will help to fund a 6-month extension for Dr Anju Velvet's PhD. So we've already funded for the 3-year PhD, and I'm going to bring in the old Brexit word. We haven't heard it for a while, but unfortunately Brexit has caused some regulatory challenges, shall we say. And the HRT study that Anju is working on had some delays in getting up and running, but we have now achieved that. And you will find on your chairs, you will have received, I mean, I don't know if the men want it, but you might be able to help us with finding patients. Anju will be talking a little bit about her study. But this is a really, really important part of the work that Anju is doing. So that's why we're looking to fund this extension, to make sure that she has enough time to complete that study. So thank you to those who have donated already. I know a couple of people here also set up their own fundraising page and linked that to our main campaign. So thank you so much for that already. And if I may ask you, you know, to share that campaign page. Those of you that use social media, help us just to get the word out and reach potential donors. That would be hugely appreciated. So at our conference last year, I highlighted some activities that SCAD will be focusing on in particular. So continuing our work to support the community. And I have just a few updates on some of that work. So firstly, we have expanded our buddy team. So Sarah has worked tirelessly to improve our training materials and to deliver training sessions, and we had a fantastic 5 new team members join, and also some refresher training for existing team members. So we are now a team of 11 who provide the one-to-one support to patients. So thank you to Sarah, and thank you to our buddies, because some of you are here today as well. Secondly, we've been really encouraged by the development of a regional group within Wales. So our trustee Harriet is located in Wales, and now they have a group of over 40 members, and they use WhatsApp to support one another, and they've been very active in, you know, getting local get-togethers, you know, to support each other. So it's really great to hear about these regional activities. So, you know, if you've met someone here today who's from your region, you know, maybe you want to start to do something similar. So, you know, we're very happy to help you facilitate and, you know, give you ideas to have some local get-togethers. And then thirdly, so hot off the press of our wonderful SCAD for Patients booklet, Debbie is now working on a similar booklet that will be for healthcare professionals. So we will release that soon. That will be available to download from our website, and you can also order printed copies. So, whenever you go and see a new doctor or your dentist or, anyone really, any healthcare professional, you can take a copy in and, help us to spread the word and continue raising awareness that way. So 3 great projects. So thanks to Debbie for leading that project as well. And more thanks. There's always lots of people to thank. The work that we do is only possible through the generosity, the enthusiasm, and the commitment of all of our supporters and fundraisers. So, everybody here, every contribution is so important, and we really do appreciate it. And I also want to extend my gratitude to our research and our clinic teams, because, the knowledge that we are gaining at quite a rate, really, when you think about it, is thanks to your hard work and your dedication. So we just have a few gifts for the team members who have been able to join us today. So if I can invite Jay, Jane, Anju, Mazhar, Shameen and Dave onto the stage, we'd just like to say a quick thank you, please. That's for you.
That's very kind of you. Thank you.
There you go. Thank you. You're very welcome. Yes, you're very welcome to take them at the end. Yeah, thank you, Anju, for all that you do. Nice. Thank you, Shameen, for all that you're going to do.
All my updates, really, for now. I mean, the main event is the research updates. That's what we're all here for. So again, I just want to thank you all for coming, and we appreciate the effort. I know some of you have travelled a long way, and some people are coming here and then doing something else, making a full day of it. So we really appreciate all the effort that you make to support us. So just to kind of press home the Beat SCAD mission, I think together we are raising awareness, together we are supporting one another. And together we will beat SCAD. So thank you all very much. And before we hand over to Dave, we just want to do a nice group photo of everybody.
Very nice. I think I'd like to start by sort of going back 12 years, which I've done a little bit with people that I've been talking to in the meeting or over lunch and stuff outside and on the walk. So 12 years ago, there was no Beat SCAD. There was no online website, no amazing leaflets. And, there were 1 or 2 people in the room who can remember back that far. I can just about. And there was no clinic, and there was no research. And your amazing Beat SCAD trustees who sit over in the corner here have been totally instrumental in that. You all know what is on the website. You all found the website. Some of you will have found the website while you were still in hospital or been given a leaflet. Before I came here, because I'm a bit sad and have few friends, I went to the office to deal with a few emails and referrals. And one of the emails that I received was from a patient who has a buddy. And this person was just saying what an amazingly positive experience having that buddy was for them, to be able to have somebody to communicate with. And, that was just this morning and just one patient's experience. So, we've got a journey to go, but, I think it's an amazing thing that's been achieved, and it's an amazing thing that's been achieved by this little corner here, in the Beat SCAD sense, and at the back as well. And also from my personal perspective, running the clinic, I get the easy bit. I get to sit in the room and have the, nice chat and meet all of you wonderful people. And there are, as you probably know, kind of totally crucial people who make that possible. There's no point me seeing you in the clinic if I don't know why you're there, if I don't have the information, if I don't have your scan. And when I've seen you in clinic and I say, well, I need to find out that bit, I need to check that bit, they're a completely critical group of people. And when you're pinging your email question in afterwards, someone's got to pick that email up. But, again, I'm not going to kind of embarrass people, but there's a little zone over here that is completely crucial to that. And then I get to travel to conferences and strut the stage and, talk to people about the research achievements. But actually, it's somebody else who's making those achievements, and that's a little bit on the front row here. Yeah, it's the people that are actually sitting in the lab, crunching the numbers, writing Python code, which to me is I thought that was some sort of amphibian or reptile or whatever they are. I just want to say a huge thank you to all of these groups, so the clinical team, the research team, and the SCAD team, because that progress that we've made over the last decade and a bit has been made because of huge amounts of unseen legwork. It's that swan on the pond with the legs that are going crazy underneath that has achieved that. So I'm going to just have a quick round of applause for all of those amazing people. So let's do a little update of the clinical services, where things are at with that, and the research and the questions and our aims and what we're trying to achieve with that. So setting up a clinical service, we all know in the country that we live at the moment, there's not a lot of spare cash. It's a shame, but that's the way it is. And that's part of the reason that we are so hugely reliant on people to allow these clinical services to happen. But we do have a clinical service. It's fragile. At the moment, the only bit of the clinical service that is funded sort of semi-properly is the bit in Scotland. There's funding from the Scottish Government. In England, it's a more fragile system that's dependent upon the particular trusts, Hammersmith Hospital in London, Chelsea and Westminster Hospital for Dr Al-Husseini's service, and obviously in Leicester. And I think the first thing, again, that we should say is that although it's a bit of a fight, we are grateful that at least we have that service in those centres, and that so far at least we are supported to continue with that. We would like a properly funded service for SCAD patients. We think that we deserve a properly funded service for our patient community because our patients are you. They are, young, fit, mums, working people, carers, all of the things that you are. And we deserve to have a proper service so that we can answer all of these people's questions, deal with these people properly, manage people properly, and research the condition. That's an ongoing battle, but we're up for the fight, and we will keep pushing nationally, locally, until we achieve that. At the moment, if you are looking for a referral to the SCAD service, then the way to do that is to find your way to the SCAD website, and you'll find that all of the comms information for the different clinical services is there. And generally speaking, in the NHS, we need a referral from somewhere, from your GP, from your cardiologist. Sometimes we can do it with your discharge letter if it says that. So reach out to the clinical teams, use the contact information there, and we will do our best to help you to get to see the clinical team if you can do that. Again, it's probably worth saying, for the benefit of the camera, that we are happy to see people face to face. Lots of people want to come face to face, want to look me in the eye and ask me a question. That's great. But we also understand that it is expensive to travel, quite a long way to travel for some people, and we are very happy to do telephone consultations, video consultations. Again, Jay and the team will help us to set those things up if that's what you need. So again, don't not engage with a clinical service for SCAD. If you want a SCAD appointment, but you can't afford to travel the distance, or it's difficult for you to get here, there are other ways to access the service. So we still need a properly funded service. We still need a nationally commissioned service, ideally for SCAD, and we will still work towards that. But at the moment, we do have a service that's going to see, I think, probably more than 500 new patients this year with SCAD across the services that we have in the UK at the moment. So that's where the clinics are at the moment. So, research. There's a lot of questions still, aren't there? So we've made huge progress, in terms of understanding and describing the clinical aspects of SCAD, talking to doctors about how this disease should be managed, when should we reach for stents, when can we not reach for, when can we sit back and allow things to heal by themselves. We know that there are scenarios where both apply. What happens to SCAD in terms of the prognosis, the recurrence risk, all of those types of things that we've generated knowledge on since the research began. But there are still key questions. What is the underlying cause of SCAD? What's going on that leads to SCAD in the patients who are affected by it? Why does one patient get SCAD and lots of other people don't? We've started this process by trying to understand the genetics of the condition, and that's been really key research which BeatSCAD in particular has supported. And back, I think, maybe 4 or 5 years ago now, we published what's called the first genome-wide association study, where you look at little variations in the genetics of patients with SCAD. You compare them to other populations and you see what are the risk genes, what are the things that are contributing to the risk. Back then, we contributed something around 400 patients to an international effort to understand the genetics of SCAD. I think about 390 patients. And the worldwide study was about 1,900 patients, less than 2,000 patients, and this was across the world. And it was, if you like, one of the first really great examples of international collaboration to try and understand SCAD. So in the last few months, some of you will have received a saliva kit in the post. Some will have already given a blood sample in the past, and maybe some will give, will receive those things in the future as part of this research. But we will be meeting on Monday late at night in order to kind of, achieve all of those kind of different time zones with our friends in Australia, Canada, the US, France, also Sweden will be involved in this as well. And in the UK, following the efforts that we've had and the funding support that we've received from BeatSCAD, I think it's likely that we will be at least 3 times the size of the first study, and maybe up to 5 times. And what I'm hoping is that worldwide, again, it'll be maybe 3 times bigger than last time. We'll have to see. But what that does is, genetic studies, a lot of research is about numbers. If you do a small study of a small number of patients, you can learn something but a small amount. If you can do a big study of lots of patients, you can make much more progress. So a reason I wanted to say that's going to take probably a year or 2 for us to get to that point. But at the moment, we know of 16 genes that are associated with the risk of SCAD. And obviously our hope is that we will know more, but also that we can delve down a bit deeper. We can try and understand, maybe are there any genes that predict pregnancy-associated SCAD? What about men with SCAD? Is there something slightly different going on there? Is there anything in there that helps us in terms of predicting what happens to patients with SCAD afterwards and so on? There are lots of different questions that we can ask if we have the size of study to be able to do things. So the reason I want to say that is because there are lots of people out there who contribute to the research. Sometimes your contribution to the research might be that you get dragged to Leicester and stuffed in a scanner and all of that kind of stuff. But actually, sometimes your contribution to the research might be that you spit in the saliva pot, which isn't necessarily the most joyous experience, but you send that off in the post to us to process. Or sometimes your contribution to the research might be that you've signed the consent form, you've given us permission to be able to get your scans and to get all the other scans of SCAD patients together to be able to analyse them and then compare them against other populations, healthy populations or people with other disease, that allow us again to say, well, hang on a second, there's something different here. And that's really important for some aspects of the research, and I'll come on to that. But what I need to say to all of you and all of you is that all of those things make a difference to our understanding of things. Other things that we will be doing. Some of you will have had an email that says, how you doing? Can you just answer a few questions for us? Yeah? And all of that information helps us because it means that all of those patients, even patients who are right at the very beginning of our SCAD journey. Those are so important because those patients from way back there, we know what's happened over the ensuing period. Yeah? But we only know what's happened if you tell us. So when you receive that email that says, how you doing? Then if you can get it back to us, it makes this massive difference to what we can understand. So in terms of what we're doing right now, there's a big push to do some more genetics research. We're really excited about that. And there's a bunch of people that are particular experts in that area that will be focused on that. But this will be about international collaboration. So it's our friends in the Mayo Clinic in Vancouver, Michigan, Australia, Victor Chang, and Paris, also in Sweden. So all of these places will be contributing, and it's so key that they do, because that's how we learn about everything. And we're really excited to be having some conversations about pooling data. So we're particularly looking to pool data around pregnancy-associated SCAD in the next, hopefully in the next couple of years, to understand more about that specific condition and what happens to patients who have that. So that's one thing. I was talking to some people, I can't remember which table it was I was chatting, about diagnosis of SCAD. And we would really like to change the current diagnostic paradigm, if you call it that, how it's done. Patients with SCAD, currently the diagnosis is based on an invasive angiogram. Most of you will have had a little tube into an artery in your wrist, sometimes the top of your leg. Pictures taken of the arteries, which enables you to make the diagnosis. But we know that some patients with SCAD, because the arteries are fragile, there is a vulnerability that those procedures can actually sometimes make things worse for patients. And most patients with SCAD, not all patients, and this is always something that I emphasize, not all patients with SCAD can be managed without stents. Some have to be managed with stents. So again, I always say that because sometimes, you can get the impression that it's always best not to touch stents, but that is not the case. There are always some cases where balloons and stents are needed, and on the whole, I have to say that the cardiologists in the UK are very good at making those decisions. And so they will usually decide correctly if it's you where that needs to be the case. But in lots of patients, the majority, we estimate probably 85 to 90% of patients with SCAD can be managed without stents. In which case, if you can make the diagnosis without the angiogram, then you don't risk this procedural complication side of things. And so we're very interested in asking the question, can we develop a new blood test for SCAD? Or a urine test for SCAD? Or a non-invasive imaging test for SCAD? So I'll talk briefly about the non-invasive imaging side of things, and then I'm going to ask Shameen will just say a little bit about what she's been doing in terms of looking at the blood test side of things for SCAD. So the imaging side of things for SCAD, at the moment, the non-invasive imaging tool that is used is a CT scanner. The problem is that CT scanners have a worse spatial resolution. They can't see things that are as small as an invasive angiogram. And so, because SCAD can be quite a small thing, CT scans will often miss SCAD, and this is a problem. And so, what we need to try and do is to develop, I feel like, a super duper charged approach to CT scan. And the first way we're going to try and do that is by using something called photon counting CT, which is a new technology which is much better spatial resolution than existing CT scans. Okay. There are other things that we have identified in the team where we look and we say, well, that's a different thing. That's an area of the arteries that's a bit different. Those arteries are a bit curlier, for example, or they're a bit bigger or a bit smaller, or maybe something completely different that we can pick out. And the team have been looking at these things. And again, this is where your consent for the research matters, because the only reason we can do this is because all of these patients with SCAD have signed consent forms, and we can get their images in, and then we can look at the images to see where the differences are between patients and people who don't have SCAD. So the aim here is to use the super duper scanner to look not just at the heart and the arteries for the SCAD, but to look at other things in the body that are associated with SCAD, and to develop a way of using the scanner to make a diagnosis. Okay? The second approach is the approach that Shameen has been working on, and before her, Anya Baranowska, who some of you will remember also started this work and is just about to viva for her PhD in the next couple of weeks. So we wish her really well for that. But Shameen, do you just want to pop up there and just give a really brief who you are and what you're doing? That would be amazing.
Okay, good afternoon everyone. I'm Shameen Noor and I joined University of Leicester as a PhD student in January this year, and I'm working with Professor David Adlam and SCAD research team. So the easiest way to explain my research is to think human body as a very busy city. And inside this city, thousands of proteins are doing multiple important jobs every second. So they are like helping to build up our tissues, they are repairing the damages, they are helping to cope with the stress, they are even helping our body to keep working normally. So when something unusual happens in the human body, these proteins may sometimes leave the clues behind. And these clues can help us to understand what is actually happening inside the human body rather than even before we can fully understand it from outside. So in my PhD, I am looking at these protein clues from the blood samples of the patients who have had SCAD, and I compare them with the samples of the patients who haven't had SCAD to see if there are any patterns that are different. So because these proteins are so many in number, so I use computer-based tools to identify these patterns that may be too small or too complex to notice by the human eye. And our long-term goal is to develop a blood test, a blood-based biomarker panel that could help us or support the researchers or the clinicians or the doctors in future to identify if a patient is suffering from SCAD or not. So the entire work is based on proteomics, that is the study of proteins in the blood. And as I'm at the very early stages of my PhD, so I'm very privileged to be part of the research that could one day help the families or the patients who are affected by the SCAD. So I'm thankful to the Beat SCAD, British Heart Foundation, and all the people who are here for supporting this research. Thank you.
Brilliant. So what Shameen didn't say is that what she's really clever at is this thing called machine learning or artificial intelligence. So, well, in fact, she's really clever at everything, as you probably gathered from what she said. But I mean, I think that these are, amazing tools. We hear some of the negative side of things in the press, but these are amazing tools for research, because what I wanted to say about this research is the vision. The research takes a long time to get to fruition, but if we kind of imagine a place where the next generation of SCAD patients arrives in hospital and can maybe have a blood test and a CT scan to make a diagnosis that's definitive, they don't have to come to see me in the clinic anymore. I'm on my island in Barbados sunning myself because I'm not needed anymore. That's the kind of vision of that body of work. And I should also mention Charles Badu-Boateng, who can't be here today. He's our RAF PhD student, so he's off doing other things, but his main focus has been around using all of your CT scans, those of you who had CT scans at the time of your presentation, to try and understand whether there are things that we can pick out from those CT scans, little details that we can pick out that we can add together for that bit. So maybe we've got the scanner bit, and then we've got the blood test, maybe even the urine test, or maybe some combination of both. And again, what Shameen is very clever at doing is using all of those things and saying, well, rather than what I tend to do, or what I've tended to do in my scientific career is say, well, I'm going to pick this one thing and I'm going to compare this one thing against this one thing and see if they're different. What the machine learning approach does is it says, look, have a look at this lot and see if you take all of this lot, what are the best things for predicting if you take them as a combination, How does it all work? And that's how that side of the research works. Yeah? I'm going to talk a little bit about the registry side of things and how the registry works, because I think this is a kind of a key aspect, and has been a key aspect of a lot of the things that we do, particularly in terms of education for medical professionals. So again, at the beginning of this, there was not much that had been described in large populations of patients about what the angiograms look like, what your cardiac MRI looks like, what the damage to your heart is afterwards, and obviously what happens to you over time. And within the UK, we are quite uniquely placed because, again, we've been going for a longer time than lots of other registries in the world for gathering that information. And Maz is going to talk to you a little bit about some of the stuff that he's been doing. So, I mean, Mazhar, again, is a multi-talented individual, but what he's very clever at doing is using or developing his kind of coding skills to bring all of that data into the right place, because there's a lot of it, to enable us to kind of maximize our understanding. And that's both in the UK and also with, again, our European partners. I think sometimes we talk a little bit about travel. Occasionally people go on holiday, I've heard. And when they do, I sometimes get asked the question, is it safe to travel? Where's it safe to travel? And actually, you'd be amazed that pretty much all of the European countries are contributing to the registry, and Mazhar is the guy who coordinates all of that. So do you want to say a little bit about that, maybe?
Thank you very much, and it's a pleasure to be here for the second time. It's actually a privilege to work with such a community that is so responsive, and many of you may have had maybe 2 or 3 emails from me in the last few months, firstly asking for saliva and then asking to see how things are getting on. But I've never come across or heard of a group of patients or a community that is so responsive. And one of the things that Prof Adlam did mention was the saliva kits that were sent out. We sent out about 1,200 saliva kits to people who we wanted to try and gather genetic data for, and we had over 700 people respond within 1 month, and that is sort of unheard of. And it's honestly a testament to the dedication, the generosity of the community, but also to the SCAD team who've built this community and this sense of belonging. Otherwise, we would not be able to get this so far. The second thing I wanted to mention with regards to my emails is that we sent out emails to people to let us know how they're getting on, and over 900 people responded to me. And a lot of people had so many different questions about things like hormones or medications and things. And I think the SCAD website is such a great resource. I don't have to answer any questions. I just say, look at this section on the SCAD website. This is amazing. This is all you need. It's just the right level, and it's the same sort of level of detail that I would use anyway. So I don't have to type anything. I'm just saying, look at this website and you'll get all the information you need. So I've had the opportunity to look after the EU SCAD registry over the past few months, and we have come to a point where we're going to analyze the data for the first 1,000 patients. So these are patients from all the way from New Zealand to Brazil. There's patients from all over the world who've had SCAD. I know Prof Adlam likes to spend a lot of time on the beach, but we had to drag him back to look at the angiogram. And be like, yes, that's definitely a SCAD. We're going to include this patient in the registry. So we've been working on that, and we should hopefully have some of the results for that at soon, and that will of course go on to the SCAD website. And the second thing that we've been working on is sort of collating a lot of the data for ourselves to be able to say, okay, well, we want to have a look at this particular, because we have a lot more patients on the registry, we want to look at this particular group. Oh, that group is really interesting. Let's just look at that, and you can sort of be able to get that data instantly and sort of be like, okay, well, we can define this group such as PSCAD or with a that's some of the work that I've been doing. So yeah, it's been an amazing few months, and it's a privilege to work for the team, and I look forward to being here for the next few years and continuing on the work.
So you may have noticed that lots of patients, not all patients, but a lot of patients with SCAD are female. Some patients with SCAD have recently had a baby as well. So there is something going on with femaleness, female sex hormones, that ties into this condition. And at the moment, we really have no idea of exactly how that works. And we have a few people who are looking at this from different angles. Katie Saxby, who can't be here today, but somebody knows her, I think. And she is using some of that genetics data that we mentioned before. So what she's doing is leveraging all of that genetics data. Again, she's like Shameen, she likes big data sets, you know. Nature doesn't want little kind of an N of 10, she wants everything. UK Biobank, everybody. And so what she's good at doing is using those big genetics data sets to say, you know, are there links between those genes that are associated with SCAD, particularly in women, but, you know, also in men, that help us to work out, you know, how does that compare to things like what age you have the menopause, or what age you have your first period, or how many kids you've had, or how does all this tie together? Can we get an angle on it that helps us to understand it? And also by bringing these data together, you can do sort of clever things to try and see whether there are routes through which hormones might be influencing some of the proteins that Shameen was mentioning through these different genes. So that's some of the work that Katie will be doing to try and understand that. The other aspect of the hormones thing, which again we kind of get often asked as a question, maybe we'll talk about it a bit later as well, is the safety of exogenous hormones, so hormones that you take as part of contraception or for HRT, and how that works, and is that a good thing or a bad thing? How does that make any difference to it? But also potentially these hormones and have a way of enabling us to try and tease out how it's working. So if we look at women who are either taking a hormone as part of contraception or HRT, or whose hormones are fluctuating and normally, does that help us if we look at their blood vessels and their heart? Does it help us to try and understand how the hormone thing is contributing to the vulnerability thing? We don't know the answer to that, but it's something that we are looking at, and Anju in particular has been focusing on as part of her research work. So Anju, do you want to just say a few words?
Hello everybody, my name is Anju. So I've been a clinical research fellow with Dr. Adlam for about 2.5 years now. So just as he mentioned, SCAD occurs mostly in females and at specific points in the reproductive cycle. So my project is mainly focused on the association of sex hormones and SCAD. So the first group that we looked at was women of childbearing age. So when I first started this project, I was like, okay, I'm not going to get any patients into this. It's going to be really tough because it was focused on middle-aged women who were busy with their own life. But I just have to say a big thank you to everyone who's participated in that study. I've had about 35 patients come in, finish the study, and they've been really supportive. And I've met some of the most strongest women in my life, actually. So thank you so much for that. So I'm working currently on the analysis on it, and hopefully we'll put it out there as soon as I finish that. So the second group is the HRT study. So we're looking at peri and postmenopausal women. So this is the first randomized control trial in the UK for SCAD patients. And so we're looking for women who are greater than 45 years of age, who have had SCAD in the last 3 years, and who still have symptoms of chest pain. So the main aim of the study is to actually assess the safety of HRT in peri and postmenopausal women, and also to see if HRT could be beneficial in the management of post-SCAD chest pain. Now, this study was actually set up as an answer to patient-led questions. So we would still be really grateful if you could support us with this study. I've left some leaflets in your chairs, so it has an email as well, and you can contact us if you need further information, or you can just come and talk to me or anyone from the SCAD team, and we can give you more information. Just want to say again a big thank you to everyone who supported us with research so far, and SCAD for this opportunity, as well as funding our projects. And again, thank you all for listening. Thank you.
So as you can see, what I try and do is surround myself with really, really talented people so that I can just sort of, sit and watch their talents be deployed. But, amazing stuff. So, yes, the HRT study is out there on the leaflet on the chair. If you meet those criterion and are interested in supporting that, that will be amazing. We can see whether HRT helps that chest pain phenomenon after SCAD in that population, at least start to learn about it and get some data in to see whether, even bigger studies might be feasible in the future with that side of things. So again, lots to learn. I think one other study that everybody's involved with at the moment is, or lots of people are involved with, is the exercise study that Noemi is running. So some of you may be in that. Yeah, I can see some people pointing at Fitbits. Just to explain this, exercise and SCAD is something that, has some associations in the medical literature, and this creates some challenges and worries and fears and things like this. We don't totally understand whether those associations are what we call causal. So does exercise cause SCAD? Or maybe they're not causal, so maybe it's just that some SCAD patients do more exercise. That might seem a bit weird. But if you think maybe about the genetics of SCAD, for example, we know that the SCAD genetics is to do with connective tissue and adhesion proteins, the glue that holds cells and tissues together. And so it might be that if you have changes in those things, your connective tissue is a little bit looser, maybe that makes you vulnerable to SCAD, but maybe makes you a bit more, potentially you might find sporting a little bit easier than I do, for example. We don't know the answer to this question, but what we do know is that we need to understand this whole area in a bit more detail. And so what Noemi is doing is she's trying to understand the exercise in the run-up to SCAD. And she's doing that by using patients with your approval, getting your pre-existing data from your devices. So if you've got a wearable, that gives great data because these things store data for ages. I didn't know this. Or your phone. Even my phone records the fact that I sit at my laptop for far too long in the day. And so it's amazing the data that we all carry on us and that is available to this. So what that means is that we can start to understand, are patients who have SCAD actually really exercising more than the same age and gender matched population out there? Are they really different, or are they really the same? And then we know that obviously when you have SCAD, you're in hospital and you stop exercising. But what happens afterwards is going to be a big spread. And some of that's going to be influenced by symptoms, particularly by chest pain. And we know that lots of patients have chest pain after SCAD. That chest pain is mostly not due to a blood supply problem to the heart. It is in some patients, but in most patients it isn't due to that problem. But it is quite a symptom issue, and that can affect how people recover. And we want to try and understand that because we want to see potentially what might be able to influence that. So not just influence the symptoms, but influence the recovery. If we develop, for example, and you'll know that we work closely with our collaborators and colleagues at Napier University in Edinburgh. And what they've been working on is an online rehabilitation tool. So we know you're from everywhere, aren't you? From all over the UK, Northern Ireland, Wales, and so on. We're all different groups across the UK. And there are amazing cardiac rehab teams all across the UK who are looking after you. But of course, those cardiac rehab teams are also looking after the 70-year-old male heart attack patient who's the more typical patient. And so sometimes it can feel a bit odd if you're a young female patient in that environment. And so what they've been working on is this online rehabilitation tool that's specific to SCAD patients. And what we ultimately want to know is, does that tool help that recovery? Does it lift people up in terms of their return to their activities? Are there other things that we can do? We know that pain is both a physical phenomenon, but pain is also about the thing between the ears. So if I crush your fingers at the same time that someone's nicking your wallet, you might notice the pain a bit less. There are interesting things between, if you like, the pain and the brain. Yes? And so we're very interested in trying to understand this, because we think that a lot of the pain in SCAD patients is probably a nerve-related pain, and it's more to do with the nerve axis from the heart to the brain than it is to do with a blood supply problem, a blood vessel problem at that point in terms of blood supply to the heart muscle. So we're very interested in trying to understand that, but also trying to influence it. And it may be that physical solutions, exercise solutions, even psychological solutions and mind exercises might be able to influence those patterns. But until we've defined what SCAD patients do in terms of their pre-exercise SCAD and then their recovery, it's very difficult for us to then say, okay, look, we did intervention X, we did the online rehab program, and look, the patients in the online rehab program had a much better trajectory to recovery, or not. Maybe it's useless, we don't know. But we need to be able to demonstrate it, because for all of the reasons, including funding and all the rest of it, if we want to be able to do those kind of things, you have to show it works. So that's another kind of really key thing. So somebody might reach out to you, particularly if you're kind of coming to clinics, we're trying to catch people early, and if they, Noemi might be ringing you and sending you a Fitbit and popping you on a treadmill to see what you can do now, giving you lots of questionnaires, giving you an app so that you can record on the app whether you get your symptoms, those kind of things. So there's a lot going on. There's a lot going on. And, as we've heard from the team, the Beat SCAD group is completely instrumental into all of that, because, we can't do the research without you. And so thanks to everybody, as my team have said already, who participates in the research in every way. Whether you think you are or not, you will be. I can absolutely guarantee all of those things. Every time you respond to an email, send something back, give us your consent to be able to get your imaging. It's making a difference to the findings that we have. So thanks to everybody who supports research. Thanks to Beat SCAD. Thanks to my team, clinical and research. You know who you are, because otherwise we wouldn't be having this conversation.
So what we're going to do is now open the floor to all of you. I've got a list of questions that other people have asked me to ask today. So we'll start with Steph at the back behind you, Jane, please.
So it's a question about troponin tests. And I think at the last conference there was a mention of the possibility that the whole process could be sped up in terms of when you present at A&E or at some kind of medical establishment. Currently, we're told, push for a troponin test if you're not feeling well, and that will be kind of the major indicator if there is something more various going on. What's the status of that research now to speed up troponin tests? I mean, I kind of imagine an ideal world where, the ambulance crew will have one, they can test it as soon as you present. You could have a home kit like you would a COVID test kit. I know that's taking it to a logical kind of conclusion, but where are we on that path?
I mean, a few initial thoughts about troponin and where it's useful, and then I'll specifically answer that question. The first thing that I think is just as important as a general thing around troponin. Troponin tests these days are very sensitive, and so they are actually really helpful in patients who have chest pain symptoms. And we know again that lots of the chest pain symptoms that happen after SCAD are not a new heart attack. They are post-SCAD chest pain, and that can be really unpleasant. But it can be tricky to work it out. It can be tricky to distinguish. It can be hard to work out what to go to hospital with and what not to go to hospital with. And sometimes it's a bit of a learning exercise to work it out. And in order to do that, you have to go to hospital a few times and have a test, and then work out that actually that set of symptoms doesn't trigger a troponin rise, and so I can be a bit more relaxed about it. And I think my message about that is that a negative troponin, if you've had significant chest pain, is really reassuring that you have not had a SCAD heart attack. And that is actually a very useful thing. SCAD happening without a rise in high sensitivity troponin is really, really hen's teeth. It's the teeth of the hen's teeth, so it's pretty uncommon. So I think that's a really useful thing. You know, I think I really like the idea of, if you like, democratizing troponin potentially, to allow potentially, you know, the idea of using it, or SCAD patients using it to reassure, and also potentially to test things earlier. I think there are two challenges there, which is why that has to be part of the research. The first is that we know that there is a time lapse with troponin. So many of you will have had a troponin that when you went to hospital, the first one was normal, if you get there quick enough, yeah? And it's only the one that's at 4 hours or a little bit later on that actually kicks up and tells you that there's an issue. And that's because there's a lag between what's going on in your heart and the marker arriving in the blood. And so if we're going to change that approach to allow an ambulance crew or, you know, to test your troponin, we're going to have to either develop new methods to make sure we pick the right person to do that in, who's had symptoms for long enough for it to be a useful measure. Because what we don't want to do is to falsely reassure people. That's the challenge. Because what we don't want to say is, okay, your ambulance troponin was fine, we won't take you to hospital. Or equally, what we don't want is for somebody with a home kit to measure their troponin at the time they have pain, is fine. And they go, oh, be all right then. But actually, 4 hours later, there was a signal there, and if they'd gone to hospital, that had been measured. So I think that there is a route here to be able to use those things with very careful instructions for people on how to do it, to make sure that they can do that. And you know, that's something that I would like to do over time, just because I think anything that de-escalates post-SCAD chest pain and people's experience of it is a good thing. But it's a journey, and I think that there's a road to go down before we are ready to be able to say, either here's a super duper early test that we can rely on the minute it's done, and also here's a system that we can give you the tests, you know, so that you can test it yourself and decide whether this is the one I need to go to hospital with or not. So I think at the moment, you know, there is a bit of having to work out for yourself what to react to. And it can be difficult. If you go to hospital with chest pain, you have a negative troponin, that is a useful learning experience, because that means that was not a heart attack. And so you can use that sometimes to make judgments next time as to whether this is a go to hospital chest pain or a let's see how it goes for a bit chest pain.
Dave, can I ask, what happens sometimes people go to hospital, they have a troponin, they get told it's okay and they get sent home. Should they be refusing to move until there's been a gap of a few hours and they've had a second troponin test?
So I think you have to ask that question. So it does depend on the interval of time between your symptoms and when the blood test is taken. So if your chest pain was 6 hours ago and you have the troponin, then it may not be necessary to have another one 4 hours later because there's already enough time interval. So this is, I think, a little bit where you have to, you know, judge and discuss with the clinical team that's looking after you and say, well, often we have 2 tests, should I have the second one or not? The message here is that troponin can help you in terms of trying to do that post-SCAD chest pain versus need to go to hospital thing, but it has to be used in the right way. And I think we have to probably wait until we've got to the point in research that to be able to roll that kind of idea out.
And I've got a follow-up, sorry.
Yeah.
And it's related, it's not quite the same, as it's related. People who are recovered from their SCAD, so perhaps they're 2 years out or more, but out of the blue are feeling sort of coronary artery spasm type pain. What advice do you have for them? Is it that go get checked out, and if it's okay, you're okay and you've learned from it? Or is there something else, you know, sort of 2 years plus down the line after having a SCAD, where perhaps they may have been hypervigilant to begin with and had some sort of anxiety related stuff on top of post-SCAD chest pain, and that has now passed, they feel well, they feel healthy, and then this starts happening out of the blue? What would your advice be there? Because it does get talked about in the support group online.
Yeah, okay. So we have to accept that there is a small recurrence risk. That's the starting point here. The recurrence risk is small, it's 10%, around 10% over 5 to 10 years of follow-up, which means it's 90% chance it's not going to happen over that same time frame. But there is a small chance that that happens. Whenever people get chest pain, you have to try and figure out, is this the one to go to hospital with or not? It's not easy. Some things that can help you. The first is heart attack pain is often associated with other symptoms. You feel sweaty, clammy, nauseous, really unwell. This is just definitely not right. You can make an argument for saying, I've been pain-free for 2 years and now I've got chest pain. Maybe that's something to think about as being different, and therefore maybe this is one to be checked out in hospital. If you get a lot of chest pain, you don't want to live in hospital. And so you have to get the balance right in terms of trying to say, okay, this is sort of similar to the one I went to hospital with before that was troponin negative. It usually passes over a few hours. Maybe I can sit this one out. It is a learning process and it isn't an easy set of decisions to make. If you are not sure, go to hospital and get a troponin measured, right? Because if that troponin is then negative, then that helps you because that's not a heart attack, effectively, yes? It's a tricky call. It's a bit of a balance and it's a bit of a judgment. On the whole, what I often say to people is you can usually trust your judgment. Most people with SCAD, it'll be often the first time they've called an ambulance or gone to hospital and A&E in quite that sort of way. And what that tells you is that if you're thinking to yourself, do you know what, I think this is just a bit of my post-SCAD chest pain, you're probably right. Whereas if you think to yourself, do you know what, this is just a bit different and I need to get checked out for this, you're probably right. So it's not an easy area, but I hope that those things can help a bit in terms of making this tricky decision.
Still on the chest pain, do you happen to know, would you, what proportion of people who have ongoing chest pain end up taking anti-angina pain drugs, and how long they stay on those anti-angina drugs for?
The first thing to say is that this kind of chest pain is common. So 60% of patients from data that Jane's been collecting in the clinic have chest pain at their first follow-up. 40% of patients are experiencing chest pain at least weekly. Many patients have recurrent admissions to hospital. So it's a common problem. In our experience, the overwhelming majority of patients who have chest pain after SCAD don't have true angina. It's not an ischemic pain, a blood supply problem to the heart pain. Ischemic chest pain or angina is a different phenomenon that is typically exertional. It happens when you are exercising, not at the end of a busy day when you've done some exercise, but when you are exercising. So the typical description of angina would be, I'm walking along at my own pace, and I get to a hill, I go up the hill and I start to get my chest pain. I stop, I rest, or I use my GTN spray, it goes away. And then I start again, and again, you get the chest pain when you're exerting yourself. Rest, it goes away. Post-SCAD chest pain typically is not exertional. It often happens at the end of a busier day. At times of emotional stress, sometimes upper body exercise in some patients we've noticed. Because it is not angina, the response to anti-anginal therapies in our experience is limited, and sometimes they're not terribly effective at all. In some patients, we've found 1 or 2 medications when we trial and error them help. You know, one of them is a calcium channel blocker, diltiazem, which helps coronary spasm, if we're a believer in that. And the other one is something called ranolazine, which is a different type of medication which can help with patients with microvascular angina. In fact, there have been studies looking at spasm versus microvascular angina, one in the Mayo Clinic, one in Vancouver, and they both basically gave kind of slightly opposite findings. So there isn't much evidence of exactly what the mechanism is. My instinct is it may be neither of those things and more to do with the little nerves that run alongside the coronary arteries than anything else. So my experience is often that if I see a patient who's got post-SCAD chest pain, a lot of symptoms, and I think, well, I'm going to have to try something here, that I try anti-anginal treatment number 1, and it doesn't really work. and I try anti-anginal treatment number 2, it doesn't really work. And then I try anti-anginal treatment number 3 and it works, a treat. But the reality is that it's around 18 months to 2 years after the index event, maybe a little bit longer, maybe a little bit less in some patients. But I think often the thing that really works is time.
Simpler question about prevalence, really. I know over the time that I've had my diagnosis, I think we went from being a rare condition to an uncommon condition. Are we getting anywhere near actually knowing what the prevalence definitely is and not getting increased numbers every year?
I mean, I can certainly tell you that the clinic referrals, Jay will tell us that, you know, there doesn't seem to be any decline in the increased rate of referrals. So what that tells us, I think we'll see somewhere more than 500 patients this year across the services in, you know, Scotland, Leicester, Hammersmith, Chelsea, Westminster. So, and I think that referral is still rising. So I don't think we're really anywhere near that yet. I sometimes say, you know, I think it's probably maybe we're seeing a third, maybe a quarter of the total number of patients out there, and those are the ones that are getting a diagnosis. So probably there's, you know, I think probably maybe 5 SCADs a day that happen in the UK, each and every single day, something like that. In terms of kind of, you know, proportions of heart attack patients, it all depends on the population that you look at. If you look at patients who have recently been pregnant and have a heart attack after pregnancy, postpartum, SCAD may account for, I think it says on there, you know, half, maybe even more than half of that patient population. If we look at, you know, women under the age of 55 to 60, it may be a fifth, something like that, you know, of those patients have SCAD. Obviously, if we look at the whole heart attack population, including the kind of very elderly and the male where this disease is less common, then it will be much lower. But of course, the critical thing for the service and for the patients is we've also got to pick those patients. We've got to pick the men, the unusual patient, the older lady who has SCAD. And also in the service, around 1 in 5 to 1 in 10 of the patients that are referred don't have SCAD. So we see the other side of this as well. We see patients who, you know, they're a young female heart attack, must be SCAD, off to the SCAD clinic. And actually when we look, they're actually patients that have maybe conventional coronary artery disease or maybe something else that's uncommon and rare, coronary embolism and so on, that, you know, we try and pick those patients up as well in the service as well. So I think one of the really key things in terms of the research work that's being done around diagnostic tools, imaging-based tools and plasma-based tools is that they may be better ultimately if we can get them to really work and they have very good predictive power. They may be better at picking the right patients out than at the moment. And I think if we do that, we might start to find a whole bit of the iceberg that we're not seeing at the minute.
So this has come up in the support group a bit recently, along the lines of, I've got my first appointment date at Dr Adlam's clinic, but I haven't had any scans, I haven't had an MRI yet. Will this be a problem? I don't want to waste the appointment by not having the necessary assessments done beforehand. Do you have a preference when people are referred to you that whether anything should have been done before they get to your clinic?
So we have to accept that the things are variable in different places in terms of access to different types of scans and things like that. There's also a timing thing. So sometimes if you do the imaging, particularly for example around cardiac MRI very early, it can give you a slightly false impression as to what the recovery potential of the heart is. It can sometimes look a bit sort of stunned and beaten up. And actually if you wait a while, it can improve quite a bit. So I think the important thing is to get into the service. We can then see, again, you know, Jay in particular has contacts. I mean, you know, she's one of the most networked people on the planet, I think, in terms of hospitals. But, you know, we kind of know how the different hospitals work, who to contact in the particular hospitals, you know, in order to try and get things done. Sometimes we might suggest getting the scans done in Leicester because we have a good setup here. We know it's going to happen, and sometimes we might have hospitals where those scans are not as easy to obtain. And then there are other centres which will send, they've kind of got a package already done, and they send the patient to the service with the imaging, or some of the imaging, or all of the imaging done already. It is variable. I think that what I would say is that don't worry, in terms of the scans that we want to do as kind of fairly standard, which is an assessment of the heart's performance with either an MRI scan or a high quality echo, ideally MRI if we can, and the head to hip scan, we will be able to get those things done, but they're also not necessarily things that you need to get done now. They're not something that's going to make an immediate difference. It feels it does because you want everything done and sorted and know what the plan is. But actually, it's okay. We can work with those timelines and make those decisions in a sensible time frame. And on the whole, I think it works pretty well. As I say, we'd like to make it work better one day. But, in the meantime, it kind of works okay how it is.
Thank you. Oh, hi. Yeah, my question is whether you've got any advice about calcium supplements, Dr. Adlam. I've recently been diagnosed with osteopenia, and my GP said, well, you need to start taking calcium straight away and vitamin D. As a SCAD patient, what would your advice be around that in general, please?
So, in general, if you have a deficiency or something that is a consequence of a deficiency or something that needs treatment with something like that, like osteopenia, osteoporosis and so on, then there is no evidence that taking treatment in that context is going to do you any harm. And so my recommendation would be that you have the other condition properly managed. Yeah. In general terms, and people will have heard my slight rants on the subject before, in terms of supplements,
magnesium, for example,
an excellent purgative, so there are lots of things out there. On the whole, I don't have great objections to different vitamins, different supplements. For the most part, I suspect that they are pretty harmless and don't cause any problems. Of course, there are no studies. There's no study out there that says, if you want to take this supplement or that supplement, does it increase the risk of SCAD? There's no studies to show those things. I think equally it's worth saying that I sit in clinic and see lots of SCAD patients. They're not all coming into me saying, shortly after I started taking my supplement X, I don't see that either. So these things are probably okay. My personal perspective is that a lot of us are vitamin D deficient because we live in a dark, damp country, and so taking vitamin D in the winter months makes a reasonable amount of sense. But for the most part, otherwise, if you are deficient in something, if you are iron deficient and therefore you have anemia or you're iron deficient, it makes sense to take a supplement because that's replacing a deficiency. For the most part, if you are taking more than your body needs of something, then your body will either poo it out, wee it out, or digest it. And so then what really is happening is that you're spending a lot of money on supplements that you could put in a jar and spend on a really good night out, which would definitely make you feel better. But yeah, I'm not going to stop you from taking your supplements if you want to, but if you need them, then you should take them.
Have you got any advice of travelling abroad for the first time?
Yes. So
read the big scan.
Yeah, my first thing I was going to say is there's a really lovely bit on this, a really nice page on this. Travelling abroad. The first thing is to make sure that you have the right travel insurance. We know there's a small risk of recurrence in SCAD patients. I've said 10% over 10 years, 1% per year, right? So if you divide that by 52 for the number of weeks a year that you're going to be abroad, that's a 0.9. These are small risks, yes? And of course, what we have to remember is that we take small risks all the time, don't we? We get in the car, we cross the road, you're getting on a plane to go to wherever you want to go, yes? So the risk here is a very small one, but equally, in the really unlikely event that you were to get into a pickle while you were abroad, you want to be able to use your insurance. So make sure that you declare things properly. One of the common questions I've been asked is, have I had a heart attack? I haven't had a heart attack, have I? I've had SCAD. Okay? And it's important to understand that SCAD is the coronary cause of the heart attack. So you've had both of those things if you've had a SCAD heart attack, yes? Just as if you'd had a conventional heart attack, that's caused by a coronary narrowing due to that disease, atherosclerosis, the different disease with cholesterol and all of that kind of stuff. So the first thing to say is make sure you have proper travel insurance that covers all of the things that you have. There are a number of insurance companies now that will specifically insure for SCAD. I think that's a real breakthrough, actually. One of the things, probably happened about 5 years ago that we first started to pick up that insurance companies were specifically insuring this condition. The second thing, which is just worth thinking about, is your personal thoughts about risk. Okay, I've said that the risk of something bad happening is really, really, really tiny. But if you are in a country that has no healthcare system, then obviously in the really, really, really unlikely event that you would have a problem, it might be harder to handle. If you are at the bottom of the ocean scuba diving, it's very unlikely that you would have a problem while you're at the bottom of the ocean scuba diving. But if you were to have a problem at the bottom of the ocean scuba diving, that might be more of an issue than if you were on the beach. It's also important to say that, we often think, SCAD, only the guys in Leicester, that's it. Nobody else knows anything about SCAD. But the reality is that, as Mazhar was saying earlier, most of our European partners, and actually a lot of places in the world that you might think about going on holiday, are part of the international registry and know a lot about SCAD. So for example, in Spain, they're running a clinical trial of SCAD. The first clinical trial of any size at all has been completed in Spain. So the Spanish doctors, I can tell you, Fernando Alfonso, big wave to him, and that group, they know more about SCAD than probably most UK doctors do. So if you go to a country that has a decent healthcare system, you've got proper health insurance, have a nice time, don't forget to invite me.
Can I just add there that on the BeatSCAD website, we have some foreign language translations of BeatSCAD literature. So it's always worth checking. And if any of you speak another language and you fancy providing a translation, we're very open to offers. And then the other thing is on part of the support page, we have links to other groups and websites of people who run SCAD support in other countries. So again, it's worth looking there to see if the country you're visiting has got that support. So I know the first time I travelled abroad and was very, very anxious about it after my SCAD mine was 12 years ago, I was going to visit family in Canada, and I went on the US SCAD support page and said, right, I need to know who's the SCAD doctor in Toronto. And I found out, and I got their name, and I put that in my little pack. And if you search information pack on BeatSCAD website, we have a suggestion for all the things you could put in an information pack to take away. So do use the search function or put a question in the support group, and I like to think of everybody being as prepared as they want to be, depending on how risk averse they are, and then putting it in a pack and basically forgetting about it and having a really nice holiday, but knowing that should you need it, you've got access to it. And I wear a bracelet which has my contact details and medical details. Some people find that a comfortable thing to do as well. But have a lovely holiday, it'll do you good. While people are thinking what they want to ask next, the next one from the group. Too many people are joining our support group on Facebook saying that immediately after their diagnosis, they were taken off hormonal contraception or HRT. And then they've asked for a referral to your clinic and they've got to wait 4 months. And meanwhile, they're having terrible hot flushes, terrible chest pain around their periods and so on and so forth. Any advice for what these patients could do while they wait for your referral, the appointment referral to come through and to see you?
So for women of childbearing age, it is, clearly always going to be higher risk to fall pregnant than with an unplanned pregnancy than to be taking a contraception to prevent that from happening if you don't wish to become pregnant, and immediately after you've had a SCAD heart attack, it's probably shrewd to ensure, at least for a period of time, that you do not become pregnant. So patients who are of childbearing age should not have their contraception stopped in hospital unless an alternative robust form of contraception has been used to replace it, essentially. For the most part, from a contraception perspective, obviously there are different approaches to contraception, but the important thing is that it is robust. So in other words, there's not much chance of accidents. So things like withdrawal and barrier contraception are not felt to be sufficiently robust, particularly for patients if you are, who are potentially taking medications that might be an issue in a pregnancy. If hormonal contraception is required, this should be progesterone-based. So you can expect if you're going into hospital on a combined oral contraceptive pill, so you're taking estrogen as part of your contraceptive strategy, that they may change you onto a progesterone-based strategy, whether that's in the form of a mini pill, an implant or a coil. Obviously a coil won't be an immediate thing, but those are all reasonable progesterone-based contraceptive strategies for people that need them. But the most important thing, as is generally the case, is to avoid unplanned accidental pregnancy. HRT gets a bad press in SCAD, and I think it's important to understand that part of the reason for the research is we don't understand all of the things around this. To date, no study has definitively shown an increase, or indeed, importantly, a decrease, potentially it could be either, in the risk of SCAD recurrence in patients who are taking HRT. But we have to accept that data are not as complete as we would like them to be. That's one of the reasons for doing the research, to try to build a more robust data understanding around this. I certainly have a lot of patients who take HRT, and I think my international clinical colleagues who look after SCAD patients also see this. I don't see, in my view, an increased risk of SCAD recurrence or an increased incidence of SCAD recurrence in patients who are taking HRT as opposed to not taking HRT. I obviously see occasional occurrences. We've said it's not a common thing, but I see it because I look after lots of SCAD patients. And I don't feel that I'm seeing all the patients with HRT coming back with recurrences or all the patients without HRT coming back with recurrences. I think I see a smattering of both. So if there is any impact of HRT on the risk of SCAD recurrence, I suspect that it is small in either direction. Could be favourable, could be not favourable. It's difficult to be absolutely adamant. Taking all this together, my view based on current knowledge, and current knowledge will change over time. So if you're watching this video in 5 years' time, just make sure that the knowledge is current. Based on current knowledge is that HRT is not contraindicated. It's not banned in SCAD patients who need it for intrusive menopausal symptoms and who have been adequately counselled as to the limitations of current knowledge, that we don't know everything about this. Because in my view, if there is no clear evidence that there is a problem with HRT in SCAD patients, there's no clear evidence of harm, I think it is a difficult thing to say you have to suffer if you have nasty menopausal symptoms. I think one thing I would say is that HRT is a treatment for menopausal symptoms. It's not really a treatment for other things. Sometimes people will come in and say, oh, I'm taking it because I'm worried about my dementia risk, or I'm taking it because of this or the other balanced risk. What we tend to see with HRT, and obviously you can talk to your GP about this and do some online reading about this, but what we tend to see is that the risks and benefits of HRT outside the context of menopausal symptoms are, they're pretty balanced. There are some things that are a bit worse, some things that are a bit better, they're probably pretty even Stevens overall. Yeah. So for me, I wouldn't be taking HRT because you've had SCAD. I wouldn't be taking HRT for other things. But if you need to take HRT because you have menopausal symptoms that are making life miserable, I don't think that that's an unreasonable thing based on what we know right now.
That's really helpful, thank you. And if we come across a brick wall of a doctor saying, I've taken you off and I'm not putting you back on, can we encourage them to write to you to get some advice?
Yeah, sure. I mean, I hope that this information is starting to get a little bit more out there. Many of you will notice that it gets into your letters when we have the discussion. So what that hopefully means is that the cardiologists, I'm sure they read them all. Apologies for the long letters, but sometimes it's about explaining things to people and making sure that people understand the reasons for the changes that are made. But yes, of course, one of the commonest questions in my inbox is around HRT, and we're very happy to answer that question and write to people and say that this is our perspective. As I say, at the moment, there is no absolute data that enables us to go, yes, this is the way to go. But, again, in my view, if there's no absolute data, then I think it's not the right stance to say, because there's no absolute data, you can't have it if you need it.
Thank you. That's really helpful. I think that the problem is with people who are, slightly in the glare of oncoming traffic headlights. They just had this diagnosis. They've just been told they need to stop HRT. Then they join the group, and the group says, actually, it's not contraindicated. Watch this video. Yeah. And they just need a bit of extra support to go back and have that conversation. So hopefully the doctors will listen.
I think the challenge is that we know this is a female disease. So we know that it peaks in the perimenopause, and we know that it has this thing around childbirth. It's something to do with female sex hormones, but we don't yet know how it fully works. And some people take that onwards to say, well, actually, anything to do with hormones is a bad thing. But I don't think that the current knowledge supports that position. Yeah. So that's the reason for saying contraception, definitely. HRT, you've heard the information on what we know, and the position that we think is a reasonable position to adopt based on our understanding of that.
Okay, I've got another one from the list. People with a diagnosis of fibromuscular dysplasia, or FMD, I know that when they are diagnosed, particularly if they come to your clinic, there will be a number of different responses that they might have as to what, if any, ongoing monitoring they need. If somebody, for example, was scanned and told they had FMD 5 years ago, would they need to request rescanning to see if anything's changed? What would your advice be on that?
So, based on current knowledge, and this is knowledge in the FMD community as a whole, as well as the SCAD FMD community, FMD doesn't seem to change much over time. I think there's an important thing to say about FMD in the context of SCAD. FMD it causes a bit of confusion because it kind of sometimes gets conflated as being the kind of almost like the causal thing. So FMD is the disease, SCAD is the consequence of the disease. What FMD actually is a radiological finding, an X-ray finding, where the artery looks like a string of beads, sequential dilation and narrowing. Actually, the term comes from when you look at this under the microscope, and under the microscope you see fibromuscular dysplasia, so fibrosis, scar tissue, muscular of the muscle cells, dysplasia all looks a bit messed up. So it's actually a histological descriptive term. In SCAD, we sometimes see the string of beads finding. Nobody has yet seen, because obviously SCAD patients do well, they survive, and therefore we have never seen on the slide whether there is actually fibromuscular dysplasia. So we don't actually know with utter certainty whether the string of beads we see in SCAD is the same thing that we see in FMD patients with primary FMD. We think it is likely because there is some overlap in the genetics of the conditions. But there are some questions in that in FMD patients, getting SCAD is very rare, whereas SCAD patients, FMD is very common. So there's a slight mismatch between these things that at the moment isn't completely understood. What I can say is this: FMD in the context of SCAD is a very benign phenomenon. It causes patients, in my experience, very few problems. Sometimes if there's a lot of FMD in the head and neck, we might think about continuing with a bit of aspirin, but it doesn't seem to cause problems or change greatly. Sometimes when we do the scans, we will find other things, sometimes little swellings of the arteries called aneurysms. Again, remember that aneurysm is an emotive word. It's a frightening word, isn't it? But aneurysms, it's all about size. So a big aneurysm has a completely different connotation to a tiny one. And the aneurysms we find in SCAD patients are often very tiny. So sometimes we might, in that context, need to keep a patient under surveillance just to make sure nothing changes over time. But only a few patients do we need to actually intervene and do something about them. So the key thing here is, when your letter comes through after your imaging and it says you've got a touch of FMD or you've got a tiny aneurysm or whatever it is, we will say if it's something you need to worry about, if it's something needs to be thought about further. Yeah. So these things are common findings, but a lot of them are almost markers of SCAD rather than something that we need to think about because it's going to cause a problem for you now or in the future. And that's a really key thing. So there are a few scenarios. Sometimes aneurysms we might keep under surveillance. Some of the dissections we will sometimes keep under surveillance for a period of time to make sure that they stabilise. And sometimes we'll find those in patients. Often they're completely asymptomatic. Patients don't know they're there. And we'll sometimes keep an eye on those things. And sometimes they change what we do in terms of the tablet treatments that we might treat you for. But generally speaking, for, if you like, your standard patient with SCAD, if there is such a word as that, who either does nothing, so nothing is found the first time round, as far as we're aware, that doesn't seem to change over time. And there's a lot more literature on this in the FMD population, which is tends to cause more issues than there is in the SCAD population, but from what we understand, it doesn't change greatly. And even patients who have FMD, again, there doesn't seem to be a great deal of change over time. So at the moment, the recommendation is that we don't re-screen people. So we don't bring you back in 5 years, 10 years, 20 years, because it doesn't make any difference.
Thank you, that's really helpful.
Just for ejection fractions, as we get older, as I get older, could that be affected more so if you've got a slightly reduced ejection fraction? But as you get older, are there any implications there?
So in our patients who have a reduced pumping function, a reduced ejection fraction is a term used for pumping function. The first thing I want to say is, and this just because this is a really common thing, is that a normal ejection fraction is around 50 to 55%. Because I really commonly get patients who come to clinic with the look of terror in their eyes and say that half of their heart is dead. And it's not. It's just that this is a biological pump. And biological pumps are only about 50 to 55% efficient. So if your ejection fraction is 50 to 55%, it's at the lower end of the normal range. Yeah? Obviously, there are some patients who are more severely affected in terms of the pumping function of the heart. And the great news here is that there are a whole bunch of new medications that have been coming online in the last few years to support the heart and to make sure that over time, the heart doesn't get bigger and have problems and issues, over time. And some of those, I'm kind of old enough and withered enough to remember when there weren't any treatments available for this kind of problem. But now those treatments are really good and they're really effective. And I think the message here is, if you do have a bit more of a hit to your heart, we are going to want to medicate you a bit more. So again, often on the kind of SCAD website literature, there are lots of patients who are being managed with relatively few medications. But this is one of the groups where we will be encouraging a bit more medication, because we know that without medication, if the heart's taken a little bit more of a hit, it's a bit more of a scar, then it can sometimes get a little bit bigger over time. And these medications are incredibly effective at preventing that from happening. So I think over time, over the course of kind of, getting older and things like that, on the whole, these things don't change as long as you are taking the appropriate medications to support the damaged area to your heart. And that's our experience. So I think it's definitely worth checking out that the medications that you're on are the right medications for a bit more of a scar on your heart. But as long as that is the case, there is, these things stay stable for, essentially a lifetime.
Right, while you're thinking of your next question. This is a bit of an old chestnut, Dave. What do I say when the doctor tells me I don't need cardiac rehab, therefore he's not going to refer me to it?
So you say, or something like that. There is excellent data out there on cardiac rehabilitation after SCAD. That was, these are studies that are almost 10 years old now from the brilliant group in Vancouver and the Mayo Clinic as well. They both did excellent studies, and obviously Noemi's doing some work in this area now. In terms of cardiac rehab, and some people love it, some people find it tricky. I think where cardiac rehab is particularly helpful is in confidence building. Sometimes, SCAD is something that knocks you for 6, right? And sometimes it's just helpful to go to cardiac rehab, even if the room is full of people who are twice your age and a different gender, and just go, okay, I'm just going to do my thing on the treadmill with all these healthcare professionals around me, so that I know that I can do this and I feel comfortable and safe to do it when I've left the hospital. So, cardiac rehab should absolutely happen. The team have done loads of talks to cardiac rehab. I've done loads of talks. I think you've both done talks to cardiac rehab teams. I know Noemi's done talks to cardiac rehab teams as well. So there'll probably be one out there that we've missed. If so, we're happy to give a talk to them. But there's hopefully the cardiac rehab service themselves should be pretty well informed about SCAD. And again, if they're not, give them a leaflet. If they want to email us and say, is it okay to exercise this patient with SCAD, then we'll say yes. We still do occasionally get the rehab professionals go, oh no, can't do rehab until you've seen Dr. Adlam. I'm like, well, what is it about me? So yeah, no problem with rehab.
I've got a bit more specific. This is about Scotland and the Scottish SCAD clinic. And some people saying that some parts of the NHS in Scotland are unwilling to refer them to the Forth Valley Clinic. Do you have any guidance on that? I know that's slightly putting you on the spot.
So I guess the starting point is I'm so excited by the fact that we now have a dedicated Scottish service that's run by two completely brilliant clinicians, Anne Scott and Claire Murphy, who have spent the last 3 years putting up with my company and going through a whole bunch of SCAD patients. And then equally, whenever there's a SCAD clinic, we get together now as a threesome and we look at all of the cases, look at all of the angiograms. So again, if you're seen in the clinic, I've kind of seen you. Yeah, I've certainly seen all of your imaging and all of that kind of stuff. So there's a fantastic MDT process around that service. So, this is really kind of, if you like, my right hand in Scotland, and they're doing an amazing, amazing job up there. In terms of getting referrals, generally speaking, hopefully, over time, it is a process. It's been a process in England. There are still a few kind of, cold zones that don't refer patients, and hopefully that's because they're really brilliant at SCAD and know what they're doing. And it does sometimes take a bit of time. If you are struggling with a referral, you can always use the email that's on the Beat SCAD website or the contact information that's on the Beat SCAD website and reach out to us in Leicester. And, we will do whatever we can to try and facilitate a process for you. Remember that to access the SCAD clinic, a referral from your GP is fine. A referral from your cardiologist is fine. We certainly in Leicester, and I suspect in Scotland as well, we'll accept a referral from your rehab nurse or your rehab physiotherapist. We don't really mind where it comes from.
Hello, my question is about exercise actually. You mentioned earlier that there is some studies that have been conducted about exercise before, but also after SCAD. What I wanted to ask is there anything that we need to bear in mind in terms of returning to exercise once you've done your cardiac rehab and you're discharging to the world back again? Like anything that we need to bear in mind that can give us more risk of recurrence that we need to absolutely avoid, or actually that is good for us to do?
Yeah. The starting point for me is that exercise is good for your heart and your body and your physiology and good for your psychology. So we should be encouraging patients to exercise. There are some associations in observational studies between SCAD and exercise, and some reports in the literature of associations between SCAD and exercise. So for example, there is an association in the literature between SCAD and what's called isometric exercise, which is where you do a heavy deadlift and you go purple in the face and lift weights. I think I might have seen that kind of scenario maybe once, and I'm not sure that the symptom onset actually happened when the person was doing the weightlifting. So the challenge with some of these kind of case scenarios is that we don't really know whether they're causal. There's a lot of people in the world lifting weights. Just because one of them happens to have SCAD, does that mean that weightlifting is the cause of SCAD? It's very tricky, and that's why we need to do proper research. But we have to acknowledge that there are question marks. And that's why what we try to do is to give common sense guidance. So because of the weightlifting thing, we tend to recommend against lifting weights or adopting stress positions, that's your planks, yoga positions, that you cannot maintain whilst breathing normally and steadily. So what we're trying to do is to avoid the thing that we call the Valsalva maneuver, where you have to sort of like bear down, go bubble in the face, and lift something up like that without really breathing. Yep. Toning weights, which you can work whilst breathing freely, are fine. A rough guide, if you can talk or sing while you're doing it, you're not holding your breath and straining by definition. It's not absolutely mandatory to sing if you can't actually, come up with a decent tune, but it's a kind of an idea type of thing. In terms of aerobic activity, it makes sense to warm up carefully, to build up slowly, and, probably not to exercise to real extremes or exhaustion. So what we'll often say is, if you want to do a couch to 5K, so people do couch to 5K, then that's absolutely fine, but start at the couch. Because the other thing that we all tend to do is, had a heart attack, used to be really good at sport, just go straight back in. And then you discover that actually not done anything for 4 months, and then you go straight back in and get your chest pain, and then it's a setback. So warm up carefully, build up. So if you're going to do a couch to 5K, that's fine, start at the couch. And then a lot of the apps are trying to get you there quickly. So in, couch to 5K in 6 weeks. And what we'd say is we want to get you there safely. So just repeat days. Do it more, take a bit longer. Take 4 months rather than 4 weeks to get there. But I'm quite happy for people to return to running. I'm quite happy for people to return to competitive sport. Maybe not, not sure about sort of more pugilistic sports, but yeah, I think we have to be really careful about wrapping people up in cotton wool after SCAD without really strong evidence to do so. So I think it makes sense to, if you like, temper the most competitive bits of what you do, and maybe some of those kind of, the real kind of hold the breath and strain thing. You think about a plank. There's a point that's reached when you do a plank where you can't carry on without holding your breath and straining. So with me it's about 8 seconds, but for the rest of you, when that happens, what I would say is that you stop at that point, and then you delactate a bit, and then you can go again until the point at which you can't carry on without holding your breath and straining. And so you can still do your 1 minute plank, but you might do it in 3 chunks, or 15 if it's me. But you get the idea. So it's just, those are the kind of things. We don't absolutely know that that's the right set of guidance, but it seems a sensible set of guidance based on what we currently know. And obviously, Noemi and the exercise side and the Napier team are really focused on trying to sort of understand that safety aspect a bit more. And I know that Noemi's going to be putting out some data around maximal exercise, aerobic exercise in SCAD patients, probably next 12 months or so, and looking at that.
I've got one final one from the group, and that is we've got a small number of people saying that they are being prescribed medication for ADHD. And I wonder if, just so we've got that on the record, if you could mention if there's anything that their doctors and they need to consider.
Okay. So ADHD medication, another kind of similar question that I guess asked lots around migraine medication, which we could cover, is a similar answer. Remember I was talking about those case reports of the, it's a bit similar here. There are some case reports of patients having SCAD shortly after the initiation of stimulant ADHD medications. There are a small number of them. It is difficult/impossible to be certain that those associations were causal, that the ADHD medication caused the SCAD, as opposed to the fact that somebody who was going to have that SCAD that day just by chance happened to be taking their ADHD medication a few days before. But we have to accept that the presence of those reports in the literature creates a question mark around the safety of those medications in patients who've had SCAD. So my view is that that doesn't mean those medications are banned. If, because of your ADHD, life is miserable unless you are taking your ADHD medication, you may choose to take what is a theoretical and reported risk, which we can't quantify, but is probably small in that I don't see loads of people on ADHD medication coming to the SCAD clinic, and there's lots of people out there on ADHD medication. Yes? But we have to accept that there is at least a theoretical or reported risk. And then what you have to decide with your doctors is where that balance lies. On the one hand, you've got what I've just described to you, that description of some case reports and a theoretical risk of stimulant medications. On the other side, you've got your symptoms. And then what you have to decide for yourself and in your scenario and with your own doctors, based on your whole clinical picture, is whether that's the right thing for you. We have similar things with migraine medication, but it's slightly different with the triptans. The reason it's slightly different, because again, it's the same thing. There's case reports in the literature of SCAD occurring shortly after triptan use, but we know migraine occurs at increased frequency in SCAD patients, and therefore it may not be that surprising that there are patients who have had a SCAD event shortly after triptan use because they share genetics, and so these two things will occur together. So does the triptan cause the SCAD, or is that coincidence? We don't really know with absolute certainty, but there is a question mark around triptans and SCAD, and that's why we tend to try and recommend not using triptans if it is possible to do that. And the thing with migraine medication is that there's actually quite a lot of alternative strategies for migraine, both in terms of preventative medications and also now some new acute treatments that can help that maybe cause less issues with migraine than triptans. My guess is that fairly soon they will be reported as having been associated with SCAD in some patients, just because migraine and SCAD probably occur in the same similar patient population and so on and so forth. So you're going to see that same kind of scenario. But what we have to say with these things is that, this is what we know. They do create some uncertainties, and we have to deal with those uncertainties. So for the migraine side of things, let's try not to use triptans if we can, and come up with alternative strategies to treat your migraine. But if ultimately those strategies fail and life is completely miserable because you get migraine every day and you can't leave the house, then we may, with you, take a decision to take a pragmatic decision that, although there might be a theoretical risk, in your scenario we've been unable to find an alternative that allows you to live your life. So it's not a straightforward answer. It's quite an individualized answer, but it's not as simple as a yes, that's fine either. And then these then become kind of balance of risks questions for individuals to think about.
I think we've all had a really good walk, good picnic, a good chat with each other, and it's been lovely to see people, and particularly well done to those of you who have really recently had your SCADs. It's so lovely to see you here. You've been amazing to get here at such an early stage in your recoveries, so well done. We will have our next full conference in October of 2027, and we hope we'll see you there. It's a bigger event with slides and more speakers, a full day event. I would just like to repeat what Beck said earlier, which is to Jay and to Jane, to Dave and to Anju and to Shameen and to Mazhar, thank you so much for giving up your weekends. You put us top of your priority list at work, and then to give up your free time as well for us. We really appreciate that. And thanks to everybody for coming today. It's been lovely to see you. Travel safely. And either Dr. Adlam will see you in clinic, or we'll see you back in this room, but it'll be twice as big for the conference in October 2027, we hope. And thank you so much for spending your Saturdays with us.